Hey everybody, so let's continue on with what we were going on for chapter 18. So this is bone marrow sampling as well as transplants. That's kind of what we had left off on. So obviously we know that your blood lineage, hematopoiesis, occurs in your bone marrow. Please remember that. And then erythropoiesis is from the kidneys. Erythropoietin is the protein that is pretty much facilitates red blood cell production. But for some patients, yes, they will need bone marrow transplant for further treatment, such as blood cancers like leukemia. So this is the lineage that we see right here when it comes to the blood lineage. This is hematopoietic system of the bone marrow where it originates. So I want to highlight a few key things here. As you can see, you first have the first level of multipotent hematopoietic stem cells. So stem cells are undifferentiated, okay? So they can become anything. So these multipotent stem cells therefore further differentiate to become pretty much different blood lineages. So some of them stay as stem cells, and then others further differentiate into the myeloid and lymphoid stem cells. Myeloid stem cells further make blood. Lymphoid make lymph, which we will get to that when we get to lymphatics for the immune system. And the myeloid does have to do something with the immune system too. So let's go down to the myeloid first. That's mainly chapter 18. You get megakaryoblast from myeloid stem cells. Those go down to further differentiate into megakaryocytes. Remember, that's Latin for cell. And then platelets are from that, which are responsible for creating clotting. Under myeloid stem cells, they can also become pro-erythroblasts. Whenever you see that in anatomy, the word pro, that kind of means before. So a pro-erythroblast proceeds and then further becomes a reticulocyte, which is a precursor, a immature red blood cell. Reticulocytes have organelles like other cells. What happens is as they mature to become a erythrocyte, which is a mature red blood cell, a red blood cell sloughs off all of its organelles. So a reticulocyte sloughs off the nucleus, mitochondria, all of it, to where a mature erythrocyte has nothing but the actual cell itself, which makes sense. There's a reason why it does that. That way the cell can carry the oxygen. Then again, you have your myeloid stem cells further make either myeloblasts, and those myeloblasts make your granulocytes, basophil, eosinophil, neutrophil. Remember, your neutrophil is your most abundant granulocyte. And then you've got your monoblasts that make your monocytes. That's under the myeloid stem cell. Under the lymphoid, it differentiates into lymphoblasts, and those lymphoblasts either become NK cells, natural killer cells, through phagocytosis, kind of kill and target cells. We're going to talk more about that when we get to lymphatics, but you just need to know they're under lymphoblasts right now. Or they make lymphocytes, which is your B and T lymphocytes, B and T cells. Again, when we get to lymphatics, you'll go deeper into that, but you just need to know this is your blood lineage, okay? Cool. So now, some alternatives to bone marrow procedures. Again, those bone marrow procedures are to get that bone marrow for transplants, for treatment. There's other techniques that are used, such as intravenous after patient's diseased marrow is destroyed. That's just showing different procedures. Not so much testable for this class, but again, let's get back to our plasma protein. So I've already talked about this, but remember, your plasma, which is made of 92% water, that formed element of your blood, contains these three proteins: albumin, globulin, and fibrinogen. So albumin is mainly to transport solids and buffers the pH. It's for viscosity, osmolarity. It impacts your blood pressure, volume, and flow. So it's a big component for osmotic pressure, which we'll get to when we learn about kidneys. Another thing you need to know is when we get to other comorbidities such as preeclampsia, one symptom of preeclampsia is proteinuria, which is actually albuminuria, which means there's albumin in your urine, and it can actually be tested for your patients. So that's an important thing to note. That means there's a formed element of the blood that is being seen in the urine, which means that there's some type of blood breakdown. For globulin, that's mainly for solute transport. It's for hormones, cholesterol, triglycerides. It helps with that transport, but also your globulins for your immunity, like I had said before. So that's really going to help with your white blood cells. And then you got fibrinogen. It's a precursor to fibrin, which is for blood clots. And we're going to get to that when we get to the coagulation cascade. Blood viscosity and osmolarity. So viscosity versus osmolarity. Viscosity is substance resistance to flow. So the more viscous a fluid is, that means the more resistant it is. So that's something to understand. If you have a highly viscous blood, more than normal, for example, higher HCT levels causing a increased viscosity for a patient's blood, then you're going to get increased risk of clots, increased risk of ruptures or damage to the vessels. That's just things to note. But yes, and then we're going to actually talk about that formula you need to know. So for osmolarity, the total molarity of dissolved particles is osmolarity. So if it's too high, that means you have too much solutes over your solvent, all right? And it'll cause a patient to have to raise blood pressure. That osmolarity is too high, the bloodstream's going to absorb the water, which raises blood volume and pressure. And we already talked about hemopoiesis or hematopoiesis. It's originated from its blood cell production, and the blood is made in the bone marrow, okay? And you have myeloid and lymphoid hemopoiesis. Myeloid hematopoiesis from the bone marrow. Lymphoid is from lymphatic tissues and organs. So there you go. Erythrocytes, again, we've talked about this a lot, but those are your red blood cells, and their main job, they're your oxygen carrying bags. They're going to pick up oxygen. And again, the life cycle for red blood cells is, 120 days. And then, yep, we already talked about this. You have two different types of hematopoiesis. Obviously, hematopoiesis is in the red blood cell, but then you also have extramedullary, such as your lymphoid hematopoiesis, which is outside. And so yeah, your extramedullary hematopoiesis will occur in organs such as your liver and spleen, and mainly outside your red bone marrow. Differentiation of your formed elements, again, we talked about that with that lineage. Please know that. Hematopoietic growth factor, so erythropoietin stimulates erythrocyte production, red blood cell production. Thrombopoietin, which is from the liver, stimulates your platelet production by megakaryocytes, which again follow that chart. And then cytokines is a group of glycoproteins for creating progenitor cells for immunity. So we'll talk more about that when we get to lymphatics. And then colony stimulated factors. You'll see CSF and other things too, like cerebrospinal fluid. That's not what this is. Colony stimulating factors are for differentiation of leukocytes, white blood cells. And then obviously interleukins are for inflammatory response. Blood doping, so this is where you increase your red blood cell count to enhance athletic performance. Some sports athletes will actually do this. So you do that from getting an influx of a red blood cell transfusion or a synthetic EPO injection, erythropoietin, and again, that is for red blood cell production. It's often banned in sports, but yeah, because by doing that, if you increase your red blood cells, you increase oxygen delivery. But of course, we've talked about this. By increasing that, you are now, instead of a normal patient, you have increased risk of polycythemia because you have increased HCT levels, which could include increased blood viscosity. So you're going to have increased heart overload. So cardiac output leads to heart strain, potential failure, even death due to thrombus and clots in extreme cases. And this is hemoglobin. It is a quaternary protein structure. Quaternary means four levels of a protein, and it contains 2 alpha and 2 beta chains, as well as 4 heme groups. So, fun fact, I know on anatomy slides, and we talked about this in class, that you have red blood and blue blood on these charts. That's not true. Your blood is red regardless, but it's usually dark red unless oxygenated. These heme components that each subunit contains, they mainly are for, their role is mainly to, once the oxygen binds to it, it increases that affinity, and we'll talk about that when we get to respiratory, but the main thing about that is when it binds, the hemoglobin turns bright red. So this is erythropoiesis, which is red blood cell production. We talked about this, and it's helped by EPO. Sorry, guys. And it takes about 3 to 5 days. It makes red blood cells. And it is hormone secreted by the kidney is EPO. Please remember that for not just endocrine, but now. And an erythroblast there's the proerythroblast, which makes an erythroblast, which makes a reticulocyte, which there makes the erythrocyte, okay? The reticulocyte leaves the bone marrow to enter circulation. Now, erythrocytes, yeah, I already talked about them. You have a lot. Males have more red blood cells than females, so higher oxygen affinity. Well, not affinity, but higher oxygen capacity. And they make about 25% of your total body cells. They're mainly for oxygen transport, as well as CO2 transport. So they carry oxygen to your tissues, and then the waste jumps onto your blood vessels, and then that goes to your heart, which then to your lungs for you to exhale. Another thing I want to point out, here it is, red blood cells stay within your blood vessels for the most part. They're like, unless there's like a disease from some like rupture of a blood vessel, they stay in your blood vessels. White blood cells, your leukocytes, will leave your blood vessels so they can travel to whatever the location of the pathogen is for defense. Because remember, your white blood cells are for immunity, okay? And we're going to talk more about that when we get to lymphatics, but please know that your red blood cells stay within your blood vessels. Your white blood cells will travel, okay? And then we already talked about, I feel like we've talked about red blood cells a lot, but again, the reticulocytes, which are their precursors, are about 1 to 2% of your erythrocyte count, your HCT count. And they have organelles. The reticulocyte does, but a mature red blood cell does not. Please know that. A mature red blood cell doesn't have a nucleus, they don't have a mitochondria, nothing, okay? And the purpose of that is so that you can have the maximum amount of oxygen. Actually, for hemoglobin, 4 oxygen molecules can be carried per hemoglobin. And it has this nice concave shape, which allows for that gas exchange. It's a rouleau formation. And they stack like coins to aid for circulation, okay? And those biconcave discs, again, it's mainly so that structures, function, anatomy, these red blood cells, they are made and shaped a certain way to optimize oxygen carrying capacity. This is a homeostasis of red blood cells. So look at this. It shows hypoxemia, which is an inadequate oxygen transport, will be sensed by your liver and kidneys. Your liver and kidneys will aid in the secretion of erythropoietin. Erythropoietin is obviously secreted from your kidneys. Thrombopoietin is stimulated, released from your liver. Then those go to your red bone marrow, and in your red bone marrow, blood is produced. So it accelerates the erythropoiesis, increase red blood cell count, and then increase oxygen. Iron metabolism. So yeah, it's a dietary iron. Stomach acid will convert that to ferrous iron, ferric to ferrous. Gastroferritin produced in the stomach will bind and be absorbed in the blood. Transferrin will then bind to ferrous iron, that's from your stomach, and will travel to the bone marrow, and that helps with, it's used for hemoglobin synthesis, and helps for, storing muscles, and so if it helps with hemoglobin synthesis, that aids for your blood cell production, okay? That's why iron is a healthy diet for those that, a lot of patients that have low iron count will also be at risk for anemia. And yep, this is a diagram that shows that iron metabolism. Erythrocyte death and disposal. So after, let's say you have some damaged blood cells, for the most part, it is your spleen that is responsible for getting rid of those. Your spleen cleans, if that makes any sense. So we'll talk more about that when we get to lymphatics. But usually, again, the life cycle for blood cells are about 120 days. In the clinic, you have your first pathology. This is anemia. So we have a couple here. Sickle cell anemia, which is what you see in this image right here. That's abnormally sickle-shaped red blood cell. You have iron deficient anemia. So we talked about iron metabolism, so that ferritin to ferrous metabolism is downregulated, therefore means reduced hemoglobin, which means reduced blood cells. Aplastic anemia and thalassemia. The biggest thing you need to know is lower HCT levels in a patient, significantly lower, is a clinical sign for anemia. And for sickle cell, best way to treat them is definitely pain meds, O2 therapy. There is recent research on gene therapy. Polycythemia is the opposite of anemia. It means elevated red blood cells. And the risk is increased blood viscosity, which could lead to thrombus, clotting, complicated circulation. You get a lot of that with patients like that. Main way to monitor patients when it comes to blood and also their oxygen levels is through a pulse ox or through ABG, which is a oximeter as well. It's more invasive but also more accurate than ABG. But pulse ox is also on the thumb or on the finger that you'll give your patient, and that measures the normal range. They say between 95 to 100%. Please note that hypoxia is like anywhere from 90 to 92% or below. So if a patient's hypoxic, you want to give them O2 therapy, either by a non-rebreather mask or whatever they might need. And then white blood cells and platelets. Again, white blood cells, also known as leukocytes, those are for defense mechanisms, for fighting pathogens and immunity. So we talk more about those when we get to lymphatics. Platelets are for clotting, and that is facilitated with thrombopoietin. And we'll see platelets some more when we get to the coagulation cascade. Yep, we already talked about this. So leukopoiesis, if hematopoiesis is blood production, erythropoiesis is red blood cell production, leukopoiesis is white blood cell production. You have two types. Again, your granulocytes, which are basophils, neutrophils, and eosinophils. Neutrophils are the most abundant. And then your agranulocytes, which are your lymphocytes and your monocytes, okay? Characteristics of leukocytes, again, they originate from that hematopoietic stem cell in the bone marrow. They're far less numerous than erythrocytes, and their life cycle is a lot shorter. It can be anywhere from hours to just a few days to a few weeks. It's not long. Whereas red blood cells, they live to 120 days. So that's just something to keep note of. And also white blood cells, they travel out of the vessel. Red blood cells don't. So please know those differences. And we already talked about that. Yep, they'll adopt distinct roles. They'll either be macrophages or they could be microglia in your cerebrospinal fluid. But again, like I said, when those leukocytes leave the bloodstream, they then take on the role of a lymphatic mechanism based off their location to help with immunity and defense. And then these are your granulocytes. So I talked about them. Your basophil, eosinophil, neutrophil. Monocytes and lymphocytes are not granulocytes. Those are your agranulocytes. A means without. So again, your neutrophils are most abundant, so we'll usually check those. They respond to bacterial infections, and they have a polymorphic nucleus. Please know this for your lab manual, guys. Polymorphic nucleus, and they're the most abundant for neutrophils. Eosinophils, please know this for your lab as well. They stain orange, like an orangish pink color, and they secrete chemicals that help destroy parasites, specifically worms as well. So they're good for parasitic combating, okay? Please know that. Then your basophils will mainly stain dark purple, and they secrete a chemical to induce inflammation, so they assist in the histamine response, okay? And we'll learn about that when you get to the lymphatics. But please know these differences between neutrophils, eosinophils, and basophils. And yet, we already talked about life cycle for leukocytes is a lot shorter. Please note that. When it comes to lymphocyte maturation, you're going to hear this from me again when we get to lymphatics, but I'll just introduce it now too. Your lymphocytes either become B lymphocytes or T lymphocytes, and we'll talk more about that when we get to lymphatics. What you need to know is B cells, stands for B, mature in the bone marrow. T cells grow and mature in the thymus, thanks to the hormone thymosin, if that reminds you of something from when we went to endocrine. So please connect the two. See how endocrine links with blood? In the thymus gland, the hormone that's secreted is thymosin, which helps aid in T cell maturation, okay? There you go. Another in the clinic, yeah, I did a walk to remember, sorry. I told you guys I was going to do some pop culture. So this is disorders of your leukocytes, your white blood cells. So leukopenia is a low leukocyte count, which gives you increased risk of disease susceptibility because you have low leukocytes, you have low defense mechanisms, so you're at increased risk. Leukocytosis, which you'll hear sometimes, that's for excessive. So low leukocytes is leukopenia, leukocytosis is high leukocytes, and then leukemia is cancer of your white blood cells. And it can be either acute or chronic. And then you have lymphoma, which again is another cancer. Oma is usually indicative of cancer. It's a malignant lymphocyte in your lymph nodes, okay? So these are different types. In a walk to remember, she had leukemia, so she had cancer of her leukocytes. A lot of times those can be treated, I don't say cured, but they can be treated and managed with bone marrow biopsies, because again, that helps with hematopoiesis and stem cell therapy. Agranulocytes. So again, your granulocytes are your big three: basophils, eosinophils, and neutrophils. Your agranulocytes, A as in without, are monocytes and lymphocytes. So lymphocytes have an extremely large nucleus. Like, hold on, let me draw it. Look at this guy. See how big this nucleus is? Holy cow. And they'll either become B or T cells, and they're important for your adaptive immunity. Whereas monocytes have this like horseshoe-looking nucleus, and they'll become macrophages, okay? So please know the difference. Platelets are for clotting, and they are a big player in the coagulation cascade we're going to go through. So their main functions, they help secrete vasoconstrictors. Vasoconstrict means to, constrict, collapse the blood vessel to reduce blood loss, form platelet plugs, secrete procoagulants, clotting factors, which we'll talk about with the coagulation cascade, stimulate the initiation of clot-dissolving enzymes, so that once the cut is done and you've stopped the leak, you don't have to maintain the clot, because otherwise then you get tissue death. Secrete chemicals to attract phagocytes for the sites of inflammation, and secrete those growth factors. So this is where platelets come. I show you the lineage again. Please know they're from the myeloid stem cell lineage, and they create megakaryoblast, becomes a megakaryocyte, which then breaks off to make platelets, okay? And they're stimulated by thrombopoietin in the liver, okay? Their life cycle is also short, about 10 days. So it's short with white blood cells. It's not long like red blood cells. So what am I getting at here? When it comes to the longest life cycle, it's your red blood cells. In the clinic, another pathology, you've got disorders of platelets. So you got thrombocytosis, which is excessive platelet count. You notice I put these in pairs, right? Thrombocytosis is high platelet, whereas thrombocytopenia is low platelet. So if I have high platelet count, you have a risk of excessive clotting, which could be tissue death, heart failure, a lot of stuff. Thrombocytopenia is a low platelet count, so that could lead to excessive bleeding, which is very scary. Platelet infusions are used for therapies for both of these, so reduce your platelet count, increase your platelet count, but definitely know the difference. Thrombocytosis, excessive, high amounts. Thrombocytopenia is low amounts. Platelet production, we already talked about this. Hemostasis, so this is the coagulation cascade. I know, everybody gets scared when we talk about the coagulation cascade. Do not worry. I will walk you through it. So there are 3 main steps of the coagulation cascade that you need to know for your exam. The 3 main steps are vascular spasm, platelet plug formation, and coagulation. So vascular spasm, in a sense, is where the vessel starts to spasm and narrow, which makes sense. Think of a cut or a broken vessel as a leaky pipe. The best way to clot it, the coagulation cascade, is plugging that pipe. So if the pipe is this big, vascular spasm narrows it so that there's less fluid leaking out of the pipe. Then the platelet plug is where the platelets rush to that site of where the open hole is and plug it to stop it. And then coagulation occurs to completely dissolve the platelet, but also to close and fix that rupture. And then, therefore, the rupture is fixed. This is effective for small wounds, but it is not as effective for a massive hemorrhage. So it's something you need to know for your patients. Like, if you get a trauma case of like a stab wound, coagulation cascade, I'm not saying it's not working. Like, it is work, but there's too much blood being lost at one point. The pipe is too big of a leak, essentially. So small wounds, this is very fixable. So step 1 is your vascular spasm. Look at this right here. See these? What happens is the contraction of that smooth muscle in the vessel walls, and then circular layers constrict that blood flow, the endothelial layers. The endothelians released by vessel lining cells and pain receptors. So actually that pain you feel from a cut is also your blood vessels kind of working right there, right? That inflammation. So it constricts those damaged blood vessels to reduce that blood flow, like I said. So see how it starts this open wound, and then look how it narrowed? See that right there? Oh. Big leaky pipe. Vascular spasm makes it just a little bit narrow. So it helps reduce the flow, but it's still bleeding. So you need to go to step 2. This usually is about 30 minutes long. Step 2 is platelet plug formation. So what happens is those platelets, which again are created by thrombopoietin in the liver, they stimulate the release by that, they will attach to the end where that hole is and form a platelet plug. Literally think of like, if I've got a straw and I get a lot of water, I'm trying to suck water through it. If I put a cotton ball in it, no water can get through. That's what the platelet plug is, okay? The platelets will clump together, become spiked, sticky, and they're just basically going to make sure nothing comes out. And it's stabilized by von Willebrand factor. There are actually different types of anemia from von Willebrand factor you'll see when you take your pathophysiology class that you'll learn. So, and this is where it comes from. Like the von Willebrand factor is important for platelet plugs, okay? So obviously these anemias for von Willebrand factor cause excessive bleeding because reduced platelet count. Again, this temporarily seals the leak, but it's only to buy time. This is not actually the coagulation. This is just buying you time so that the coagulation cascade can occur, okay? Coagulation cascade is step 3. Steps 1 through 3 is hemostasis, which is homeostasis is maintaining body balance. Hemostasis is maintaining your blood balance, right? So the platelet plug is just to buy you time so that coagulation can occur before the patient dies, essentially. Step 3 is the coagulation cascade. So there are different pathways. You've got an extrinsic pathway, which is triggered by trauma, like a stab wound. An intrinsic is initiated by an internal vessel damage, like organ damage. But both pathways converge around the common pathway to complete the clotting. There are 12 factors, and it's technically numbered Roman numerals 1 through 13. 6 is actually just a placeholder. You don't need to know the 12 factors, like each one's name and everything, but you should have an idea of them in order. And it depends on calcium ions and vitamin K. So I will expect you to know the order of the coagulation cascade. So let's go through it together. And we'll obviously go through it in class too. So these are your big 12. Look at that. 1 is fibrinogen. Huh, where did we see that before? Fibrinogen's in your plasma, remember? So then you've got prothrombin. Pro means a precursor, so it helps make thrombin for clotting. These are both in the liver, by the way. Fibrinogen's converted to fibrin. Prothrombin converts to thrombin. Then you've got tissue, which is factor 3. 4 is calcium ions. 5 is proaccelerin. 6 is not used. 7 is proconvertin. 8 is antihemolytic factor A. 9 is antihemolytic factor B. 10 is Stewart power factor, thrombokinase. A kinase adds a phosphate group. Antihemolytic factor C. So you don't need to memorize all of these. I'm going to show you like the common pathway that you should know, or at least have a gist of. And then yes, Hagman factor 12, and then fibrin stabilizing 13. So the coagulation cascade, let's break it down. This is the basis. I don't want you to know every single step. This is the basis I want you to know. So I kind of summarized it. Clotting factor X10 plus prothrombinase come together to make for clotting factor 2, which is prothrombin, which is the inactive form of thrombin. So it has to convert to its active form, thrombin. So first, clotting factor 10 plus prothrombinase. ACE is an enzyme, by the way. Anytime you see ASCE, that's an enzyme. So these get together to make clotting factor 2, which is prothrombin. But it's inactive. Thrombin is responsible for clotting, right? For platelets and stuff. So since it's inactive, we've got to activate it. So it's going to convert to the active form, thrombin. And then that converts to clotting factor 1, which is fibrinogen, which is also an inactive form for clotting. So then that's got to become fibrin to form a clot. And then clotting factor 13 is what stabilizes the clot, okay? When it comes, so basically in order, it's 10 to 2 to 1, oh my goodness, to 13, okay? And in order, the prothrombinase goes to prothrombin. So prothrombin becomes thrombin, and then fibrinogen becomes fibrin, and then the clot is formed. So that's making a clot. What if I wanted to break a clot? That's called fibrinolysis. That is backwards. So basically plasminogen converts to plasmin to break down the clot. And then bradykinin is for vasodilation, which helps relax that smooth muscle to open it, vasodilation, to reduce that vascular spasm. So these are the two things for fibrinolysis, which is, so yeah. Okay. And again, these are the extrinsic, intrinsic, common pathways. So obviously extrinsic pathways for tissue damage outside the body, think extrinsic, external, so like a stab wound or trauma. Intrinsic, internal, so think like organ damage or blood vessel ruptures within, and then your common pathway will converge with both of them. Oh, and then this is this is definitely a schematic of it. And this is kind of me talking about, we already talked about this fibrinolysis. So remember, plasminogen becomes plasmin, and then obviously the bradykinin, which helps with vasodilation. Clotting disorders. So here are some clotting disorders. You got hemophilia is the main thing. Hemophilia means a deficiency in clotting factors. So hemophilia patients will bleed easily, which is very scary. Like a cut would send them to the ER. Thrombosis is abnormal clotting. So hemophilia is low clotting. Thrombosis is high clotting. So just kind of be aware of that. This isn't a pink slide, so that means it's not a clinic slide for your pathology, but it is important to know. Discovery of blood groups. So now we're getting into blood typing. So the historical context, blood transfusions were once very risky because of unknown incompatibilities. Obviously, let's think about it. If you're type B positive blood and you take in type A blood, it's not going to mix well because they each have different antigens. So if that's the case, then the issue you run into is clotting and death. So in 1900, Dr. Karl Landsteiner, who was an Austrian biologist, discovered the major human blood groups. And it helped understand donor-patient compatibility, and to this day, what we use for blood transfusions. This is actually what you're going to do in your lab, so this is what I'm going to introduce now. So you've got your antigens, antibodies, transfusions. Your antigens are substances that trigger an immune response if recognized as foreign. We're going to talk more about them when we get to lymphatics. But think of an antigen as, if I see this, I'm going to fight it. So it's found on the red blood cell surfaces, also called isoantigens or agglutinogens. You'll hear either name. I think on the test I just use antigens. Yeah, I didn't use isoantigens or agglutinogens, but it's fair game for your boards. Antibodies are proteins, immunoglobulins, produced by B lymphocytes, called isoantibodies or agglutinins. They bind to foreign erythrocyte antigens, causing that agglutination, which is like clumping and everything. So when it comes to antibodies, if it clumps, let's talk about this. That means it is that. If it has an antigen triggering an immune response, it's not that. So a lot of times when you're doing blood typing tests, that the antibodies will bind to the foreign erythrocyte antigens, causing that clumping. It's important to know because agglutination would cause blockage of small blood vessels and could cause kidney failure and all kinds of things, poor oxygen perfusion. So it's important to know the antigens and antibodies you see on your surface to understand if this blood is viable with your blood type. So let's get into blood types. Here they are right here. So basically, blood type determination, you have different types. You have type A, B, AB, O. The antigens you have are, you have A antigen, which is what it is, B antigens, both A and B antigens for AB, neither A nor B antigens. And then obviously, yeah, like I said, O has neither A nor B antigens, right? So this is important because your antigens are what you have. So when you're doing a blood typing, and I have your lab manual right here for what you're doing, the blood typing ABO type here, let me see if it'll show on the screen. It might not, based off the, sorry, because of the blurring background. But if you go to figure 3.16 in your lab manual, it talks about the blood typing, and this is like an exercise you're going to do for activity 3, where you're trying to find what the blood type is. So it talks about anti-A, anti-B, anti-D, and control. The antis are your antibodies. So if it agglutinates with that antibody, that means that it can't be that. Does that make sense? Because if it agglutinates, you're facilitating a clot when you do blood typing. So if it clots with it, it can't be that. So when in doubt, please use my slide to help you too. So type A blood is going to have an A antigen, but anti-B antibodies, which just means it has A because it is A, but it can't mix with B, type B blood, okay? It will clot. So that's why on your test, when you do exercise 3.16 for activity 3, that's what that is. So I'll give you an example. I wish I could pull it up, but let me see if I can draw it on here to make it easier. So the first line, which is O positive, it's got anti-A, it didn't clot. So if it didn't clot, that means it has that antibody. Anti-B, it didn't clot. Anti-D, antibody, it did clot. And the control, obviously, like, the control is supposed to be, you know, it's the baseline. So this is O positive. So this is anti-A, anti-B, and then anti-D. D, by the way, is the rhesus factor, which we'll talk about in a second. So that's either for that's for the plus that you see. So since it had since anti-A and anti-B antibodies did not clot, that means that there was no presence of these antibodies. So not that there was no presence. That means that there was a presence of these antibodies because there was no mixing. Because again, think of a clot means that it can't be that. So because anti-A antibody and anti-B antibody did not clot, that means this blood does have an anti-B antibody and an anti-A antibody. And then the anti-D, it did clot. So that's a means it doesn't have the rhesus factor. So this is a little confusing. I understand that. The biggest thing when it comes to it is your antigens are based on the presence or absence of those A or B glycoproteins. So if you have like an A antigen, that's a type A blood. If you have a B antigen, it's a type B blood. If you have AB blood, some of you have AB blood, you will have both A and B antigens. If you have O blood, you're going to have no antigens on you. Now, when it comes to antibodies that your body fights against, type A blood is going to have anti-B antibodies because it means it's not going to be able to work. It will clot with type B blood. Okay, so you see where I'm getting at with that? So what that means is type AB blood is known as your universal recipient or universal acceptor. They can accept anybody's blood because they have no antibodies. That's important to know for your lab. Because they have no antibodies, they are the universal recipient. Type O blood, because it has no antigens on them, they are the universal donor. Okay, specifically O neg. There are no antibodies, therefore it is the universal donor. And this is kind of showing the different, epidemiological scale of different populations and what type of blood type they have. And this is a chart that you're going to see. Actually, I think it is shown figure 3.14 on blood typing. I would study that, not just for your pre-lab quiz for chapter 18, but just so you can understand what you're doing for the lab. But this is bringing it home. Look at it. AB has no antibodies, so it's the universal recipient. But it has both antigens, so it cannot donate, though. It can get from anybody, but it cannot give. O is opposite. It has both antibodies, so it can't receive anything but O blood. But it can donate to anybody because it has no antigens, okay? So please understand that. This is, a schematic showing the fluidity of blood, and this is a diagram for rhesus factor. And we'll actually talk about that. So when it comes to sampling, this is kind of what you're going to see for your lab. So this sample has anti-A, agglutinated red blood cells. Agglutinated means clotted. Anti-A, B, anti-D. So based off your diagram you see here, it agglutinated, so that's what it has. These antibodies agglutinated, so think of it as like it's kind of letting you know what that is. So this one would be A positive. So kind of follow your chart, 3.16 for blood typing. The rhesus group, that's also known as the D antigen. And it's present in about 85% of Americans. If you're rhesus positive, it means you have the positive. If you're rhesus negative, then you don't have the D antigen. For example, I'm B positive because I'm positive. But I B positive. But yeah, that means I have the B antigen and the rhesus antigen, okay? This is important when it comes to certain pathologies. But yes, matching your blood type is very important for transfusions to predict transfusions for patients to reduce blood clotting. And then your final pathology, yeah, we're right at the end. This is called hemolytic disease of the newborn or erythroblastosis fetalis. So what happens is it's a blood disorder in which a mother and a baby have incompatible blood types. Remember I was talking about antibodies? They're like your immune defense. So they will attack the baby thinking it's a foreign invader. So this isn't the first pregnancy, but the second pregnancy. Because again, your body gets used to, when it's exposed to something, you'll learn this with lymphatics, it pretty much gains an immunity from it and recognizes and creates antibodies for it. So your mother, if the mother is rhesus negative, and after their first pregnancy, the baby, let's say they have a baby and their partner has rhesus positive blood. So like, let's say I'm B negative. I'm not B positive. But let's say, for example, my blood type is actually B negative, and then my significant other is B positive. We have a baby together, and that baby comes out B positive. Because I have a antibody for the rhesus gene, the D antigen, the baby will come out normal. Like, there won't be any complications for the first pregnancy. But what will happen is my body will build up antibodies for the rhesus antigen, for the D antigen. So you see that happening right here. First pregnancy, those blood cells are interacting with the mothers, and they usually interact with the placenta. We'll talk more about that with repro. But what you need to know is, on a blood side, is that once that baby passes through your body, the woman's body is gaining antigens for the rhesus gene, which means if that rhesus positive antigen is present in the baby will be seen as an invader, like a pathogen, and the mother's immune system will actively fight this by causing hemolysis of fetal red blood cells, which makes the pregnancy inviable. So it could lead to severe agglutination, hemolysis, which is fatal to the baby. Some signs and symptoms for the mother is pale or jaundiced skin or eyes. Jaundice is yellowing. An enlarged spleen or liver, because again, it's working overtime. The spleen cleans your blood. Fluid buildup in your stomach, lungs, or scalp. So treatment for this, it's called RhoGAM. It's named for rod immune globulin human injection. It's actually an injection. So if a patient, and I actually have a buddy, like, she's negative, she's B negative, and her husband is, I think, like A positive or something. I don't remember what it is, but like, because of that, her baby actually ended up having type positive blood. So what happens is that at 28 weeks of pregnancy with your first child, the mother will get injected with RhoGAM. It does not hurt the baby, but by doing that, and then a second dose will be given 72 hours after birth too, of that rhesus positive gene baby. That way, the patient, if they have a second pregnancy, it doesn't get attacked. Basically, your body's not going to build up antibodies for the rhesus D antigen. Okay, so that's something interesting. When a patient, if you know that their baby, and you do blood tests to verify that their baby has a positive, they have the D antigen, and the patient does not, the mother does not, you're going to inject them with RhoGAM at 28 weeks pregnancy, and then again 72 hours after, okay? But that is erythroblastosis fetalis, hemolytic disease of the newborn. Okay, this was long, but we have finished everything for chapter 18. When we reconvene, we will go over this chapter, we will go over everything, but good job, guys, and I'm here if you need anything, okay? See ya.